this. Broadcasting from the historic Hayburn Building in downtown Louisville, it's time for Single Payer Radio, a project of Kentuckians for Single Payer Healthcare. We're an affiliate of the Kentucky chapter of Physicians for a National Health Program, and we're a longstanding community partner with Forward Radio WFMP LP 106.5. Just want to let folks know that the views and opinions expressed here on Single Payer Radio are those of the speakers and not the station. And just to remind folks that you can listen to Single Payer Radio on Mondays at 2 p.m., Tuesdays at 7 a.m., and Wednesdays at 11 a.m. If you can't pick up our signal, you can stream us live or go to our SoundCloud here at forwardradio.org. And Mike, just a couple quick notes. We got some good news that the first of the year that the patients have a new billing protections when getting emergency care and non-emergency care from out-of-network providers at in-network facilities and air ambulance services from out-of-network providers. And also, listeners will know that over the past few weeks, we've been talking about the direct contracting entities that are privatizing traditional Medicare. And over 50 congresspersons, including John Yarmouth here in Louisville, have called on the Biden administration to end these direct contracting entities. As corporate media outlets are currently leading off their news reports with Russia being posed to take over Ukraine, there's hardly been a whisper in the past few decades about the corporate takeover of our healthcare system, especially Medicare recently. The big Medicare Advantage players keep getting bigger. That's a $412 billion market. The federal government pays Medicare Advantage plans more than $1,000 every month. And just to remind listeners that with the Medicare Advantage plans, they can limit the doctors and hospitals in your network. There's more pre-authorizations for certain procedures. They spend less on care, but cost taxpayers more than traditional Medicare. And people who enroll in Medicare Advantage often can't buy Medigap insurance or Medigap plans if they decide to switch to traditional Medicare. By the way, United Health reported 2021 profits of $24 billion. That's B with billion. After they took $287 billion from consumers. The average employer-sponsored family policy in 2011 cost an average of $15,000 a year. Last year, a family employer-sponsored family policy cost over $22,000, a 47% increase. Plus, we're paying twice as much out of pocket. Mike Flynn and Dr. Gene Big Poppy Shively. So, Mike, I'm going to turn it over to you.
All right, thank you. The only thing I can say about what you said about is just welcome to the United States healthcare industry. All right, my name is Michael Flynn. Let me begin with the usual disclosure or disclaimer that any comments that I make during this program are my own personal comments and do not represent the views of the Department of Surgery or the University of Louisville.
I'm Dr. Eugene Shavely. I'm a retired general surgeon from Campbellsville, Kentucky. The remarks that I make do not represent Taylor Regional Hospital nor the Department of Surgery at the University of Louisville.
Now, our topic today are issues related to the nursing profession, a group that is being slammed in a number of ways, especially with the pandemic, and had a lot of issues going on even before that. We have a special guest today, Suzanne Gordon. Suzanne was gracious enough to come on our program back in October to talk about VA health issues. I learned a lot, very informative program. Suzanne has a resume as long as my arm. I'm just going to mention a few highlights, and then we're going to let her make some comments. She's a journalist and an author, has written 11 books on nursing and health, VA health issues, has had articles in the New York Times, the LA Times, the Washington Post, and the Journal of the American Medical Association, just to mention a few. Suzanne, welcome. We're glad that you're back with us again. And as we've done with previous guests, and the last time you were on, we're going to give you an opportunity to make whatever comments you'd like to make about nursing issues in this country today for as long as you want, and then the conversation will begin.
Thank you. So I'm a healthcare journalist and researcher, and I actually have written, co-edited, or co-authored 21 books. I'm just coming out with a new book in July that I wrote with my husband Steve Early and a colleague Jasper Craven, called Our Veterans: Winners and Losers, Friends and Enemies on the New Terrain of Veterans Affairs. And I would like to mention one little thing maybe at the end about VA issues, but I started writing about nursing in 1986-ish. I think, like most Americans, America has discovered nursing in the COVID-19 epidemic. They were there all along. And it shouldn't have taken a pandemic to teach people how important nursing is. I like to say that nursing is the sort of visibly invisible profession. I mean, it's kind of like the VA, we all know it exists, but we don't really know what it does. I mean, it's interesting, and I can talk about this later, the parallels between my writing about the VA and my writing about nursing. But I grew up my father was a famous doctor. I'm sorry about the phone in the background. Okay, great. Thank you so much. My father was actually a famous doctor. He's been dead since 1970, but he developed the use of ACTH and cortisone for inflammatory eye disease. And he was a professor of ophthalmology at Cornell Medical School, New York Hospital. So I kind of grew up among the women in white, and they were all women, and they all wore white back then. And because we went to the doctor's dining room, I never really knew anything about nursing. I knew they were there. I had no idea what they did. My father had a nurse/secretary who introduced herself as Dr. Gordon's nurse, just like my mother was Mrs. Dan M. Gordon, and it was interesting because I never knew anything about her. It turned out that her brother, who had been had a disability from birth, was America's foremost chess teacher and taught Bobby Fischer, who some people our age would remember who Bobby Fischer was. And I don't know if Miss Collins knew how to play chess. I know nothing about her. It was just extraordinary. And I began, and then, I was raised on television shows like Marcus Welby, MD, and Ben Casey, and all these shows where the doctor did all the caring and, of course, all the curing. And, then there was Chicago Hope, which I always call Chicago Hopeless when it comes to nursing. But you name it, these shows were awful. And basically the doctors did all the nursing, and nurses were just kind of there for color. And I discovered nurses when I had my first child in the hospital in 1984. And my friend, who was my OB, she was, basically nowhere. And it was the nurses who got me through the back labor. I mean, she did come in and help get the baby out. And then in my 4 days in the hospital, and those were the days when women had 4 days in the hospital, not 4 minutes, the nurses really got me through teaching me how to take care of my baby. And, my friend, the doctor, Dolores, would sort of bop in every once in a while, but she's pretty much irrelevant. It's interesting because my daughter just had a baby, and she had a placental abruption, which for your listeners is a catastrophic complication of pregnancy. And she was very fortunate to be near a Kaiser and get in right away, and had an emergency C-section, and the baby was born 6 weeks premature, and spent 3 weeks on the NICU in the neonatal ICU. And the nurses were just amazing. I mean, the doctors were fine, but it was the nurses who did everything. I discovered nursing. I shouldn't have had to know what I didn't need doctors to know that doctors were important. I didn't need to have surgery when I was 20 to know that doctors were important. You grew up in a culture where doctors were gods and they were important and so forth. But you did need to be in the hospital pretty much to know what nurses did, because nobody in the media told you. Medicine pretty much dominated and still dominates the media image of nursing until COVID. I began, after I had my baby in the hospital, my first baby, I realized, wow, I have things wrong. I don't have the correct image of healthcare. And it's very hard for people to have the correct image of healthcare in the world that we live in, because even if you pay attention to nurses want you to think that they're the only important people on the stage. There's this extremely competitive view of healthcare, which is really not correct, because it, just like it takes a village to raise a child, it takes a village to take care of a sick person, or even to keep people from getting sick. And in our dominant framework, nurses are competing against doctors, and nurses are constantly saying they're the ones to solve the healthcare crisis, and you should give them all the power. And in fact, I don't agree with that. I think that we need a collaborative model, because, and we can get into this later, in healthcare, toxic hierarchy is a gift that keeps on giving. And doctors refer to nurses as physician extenders, and nurses refer to nursing aides as nurse extenders. And we have this kind of Adam's rib view of healthcare, which denies people their agency and also the role that they play. You guys, one of you is a surgeon, right? And Jean, you can do the best surgery in the world, but if those housekeepers don't disinfect the room right, the patient's kind of in big trouble. And if the pharmacists don't do it, and the nurses and the nurses' aides and the dietitians and so forth. And I think it's extremely difficult for people raised in our society to give each other credit and to say, I'm different rather than better. And you see this in nursing as well as in medicine. So I began writing about nursing after my first baby was born. I spent 3 years in the Beth Israel Hospital in Boston when it was a standalone hospital and a great hospital, and had an amazing management structure where there was a partnership between the CEO of the hospital, who was the doctor, and the chief nurse, who was nurse. And they developed this model of primary nursing where they developed a model where a patient would be followed by a nurse as much as possible, a primary nurse, throughout their hospital stay. And of course, that was easy back in the 90s when people stayed in the hospital for more than 40 hours, called Life Support, 3 Nurses on the Front Lines. And then I wrote a book called Nursing Against the Odds. Oh my God, I wonder if I can, and the subtitle was Nursing's Relationship to Medicine, the Media, and all kinds of stereotypes about nursing. And then I've done a lot of work on helping nurses tell their story, because nurses don't talk about their work. Or when they do talk about it, they talk about it in very sentimentalized ways. I mean, it's interesting because the COVID epidemic has replaced one stereotype of the nurse, the angel nurse, the caring nurse, with another stereotype, which is the hero nurse. And none of those stereotypes are, of course, accurate. And what I think is really important is that nurses tell their stories, and and that they do it in a way that shows their knowledge and skill. Nurses aren't heroes, unfortunately, like doctors today or anybody who works in healthcare, because we have no public health system and we don't have a collaborative health system, and we don't give nurses the pay and respect and working conditions they deserve. You have to kind of be a hero to go into a hospital today, no matter who you are. I'm supposed to have a first meeting with a new primary care doctor today, and I was enormously relieved when they announced that it would be virtual, because I don't want to go near anyone that I don't have to go near. But there's just lots to talk about in nursing. I think nursing culture is got a lot of flaws. I mean, anybody who thinks that if women were in charge, they would do better than men, should just look at nursing culture to see how far that myth gets you, and we can talk about that. Nursing is dominated by management, which is why we have the conditions that we have today. And also, another reason why we have the conditions that we have today is that doctors, and I think this is really scandalous, don't know what nurses do. And when nurses try to get safe staffing ratios so that they can take better care of the doctor's patients, because the doctors don't conceptualize the patient as our patient, they conceptualize the patient as my patient. Doctors don't come out and fight to support nurses, which is fighting to support their patients. They often either stay silent or they oppose these efforts to get staffing ratios. And I think that's really tragic. On the subject of doctors, and please don't think some of my best friends are doctors. I think the medical model, and I know you probably all agree, is pretty much a terrible model. As it is in American society. It's hierarchical, patriarchal, et cetera. But I think that, I don't think the nursing model is much better. It just substitutes another matriarch, as it were, for the patriarch. But one of the things that sticks in my mind very much, because it is kind of like America's reaction to nursing today in the COVID epidemic. Arnold Relman, Bud Relman, who was, one of the enormously famous medical leaders. He was an editor of the New England Journal of Medicine. And he wrote an article. It's really worth looking up because it's so extraordinary. I think he was 91, I think. And I had been on a number of shows with him. And one of the things that as a non-nurse, but as a woman, one of the things that always happens when you're on a radio show like this is quite different what you're running. But often if I'm on a radio show with a doctor, the host will sort of privilege the doctor, whether it's a female or a male doctor, by calling that doctor Dr. Jones or Dr. Smith, and me, I'm Suzanne, And I was on a couple of shows with Relman and always would have to establish with the host that if he's going to be Dr. Relman, I'm going to be Ms. Gordon or Professor Gordon. And if I'm going to be Suzanne, he has to be Bud, and of course he never wanted to be Bud. So I always insisted on this. But anyway, he wrote this article and he had a terrible fall, ended up in the ICU for something like a month and then in the hospital. And he wrote this article. So he's like 91. I think he was 91. He was very old. And he suddenly discovered nursing, right? I mean, he's flat on his back in an ICU and then in the hospital. And he discovers two things. One, gee, nurses are important. Wow, who knew? And two, that doctors aren't really very nice to patients and don't tell patients much. And I thought to myself, okay, so he's 91 or whatever he was, and he probably graduated medical school when he was 26 or 7. So it took him 70 years, 60 years to figure this out. I mean, if every doctor has to end up in an ICU to figure out that nursing is important, we're really in trouble. And if the society has to depend on a pandemic, to figure out nursing is important, we're in trouble. And the reason why we're in the kind of trouble we are, I mean, there's many, many reasons, but when it comes to nursing is it's way too late to discover the importance of nursing or medicine or retail clerks or public health when you're in the middle of a crisis. You really need to prepare. It's the same thing with the primary care crisis, right? For primary care doctors and providers. And we don't have enough nurses. We don't have enough hospitals. We don't give nurses the pay and the working conditions they need. There was an article in the New York Times yesterday about Mississippi having a shortage of nurses. Really, how surprising is that? A state that treats nurses kind of like slaves. Nurses don't want to stay in the state and so forth. So I think we have a huge healthcare workforce crisis in America.
Suzanne, and for all of those reasons, that's why we wanted to have you come on, and we wanted to talk about these nursing issues. As a matter of full disclosure, both Jean and I are surgeons, and we're both married to nurses.
Oh,
so
yay.
we have been hearing a lot of these things you've said, and so we're good to go. Jean, do you want to start the question? Jean's got a couple of interesting questions for you about some of the things that he's found out about you.
Well, I agree with you in all that you just said. And I was reading an article in Meditech just a few days ago, and where they had done a survey of a large group of nurses. And I thought that one of the biggest gripes was going to be the relationship between doctors and nurses, but was not number one. The number one gripe was administration, not just a nursing administration, but administration of the hospital. And the gripe with physicians was way down on the totem pole. And I think that's the number one gripe of many physicians is administration. Nurses are overwhelmed with paperwork, and they don't have time to nurse like they used to. I mean, can you comment a little bit about the waste of time nurses do on paperwork and computers and administration?
Agree. I completely agree. I think doctors and nurses share more and more in today's corporatized healthcare world, or it's really, can you call it healthcare anymore? Corporatized health delivery, whatever, health sales world. And I think that too much paperwork, dealing with the computer. I mean, the nurse has the same problem that the doctor does, you have to do all this work, and there's no accommodation in your workload for that work. I mean, the computer has essentially become another patient that healthcare professionals have to deal with. And, and that's why, and it's becoming really arduous, and there's no accommodation made in the workload. And of course, actually, it's almost the opposite, because every patient that you add, like for physicians for their patient panel, or for a nurse for the patient they're caring for in a bed or in the home or whatever, you have to add on that paperwork workload. So, it's if you as a physician are seeing 30 patients a day or 25 or however many, you have to multiply that by the paperwork and the computer work that extra patients or that number of patients demand. And, when they introduce computers into the nursing, into the nurses' duties, they claimed that the computer would somehow make it easier and actually make less work. And it's, of course, made more work. I mean, I want to tell you a really funny story about computers, because this just shows that, the issue of administrators. I mean, if you had administrators who understood the nature of the work, then they might administer differently, right? Or if you had administrators who weren't serving sort of essentially corporate masters. But a friend of mine was an orthopedic nurse at UCSF, and they put in the computer system, and then they decided that they were going to put the computers in the patient's rooms. So rather than consulting the nurses about where in the patient's room might they put the computer, and I think this story is emblematic of the whole problem, they just went ahead and spent a lot of money putting the computers in a space right at the entry of the room, right behind the door. So the nurse would be standing at the door, and somebody would open the door, and the door would whack the nurse standing and entering stuff into the computer. And they got so many injuries from the nurse getting whacked in the door that they ended up having to change the system. But this is the problem. Nobody asks nurses, how many patients can you handle? They will tell you, how should you do your work? How can it be more effective? What can we do to help you? And I think this is just true everywhere in healthcare. And when you start asking frontline people how you can redesign the work, then they tell you we need safe ratios. They'll tell you how many. It's very interesting, this whole fight about safe ratios, safe nurse-patient ratios, which is another place, Jean, that your comment proves, which has been opposed by nurse administrators, right? It is nurse and hospital administration that has lined up to oppose these ratios that nurses have fought for. The only place they've won them is in California, and in Australia, they now have them everywhere. But initially, in the 90s, they won them in California, and it was the California Nurses Association, which is now the National Nurses United, won these ratios. I tell the story of how they won it in the first edition of the book that I wrote with Bernice Baresh called From Silence to Voice, What Nurses Know and Must Communicate to the Public. And we tell the story about that fight. And then I wrote a book called Safety in Numbers with a couple of colleagues actually in Australia. And we tell this a longer story of how they won these in California and the state of Victoria in Australia. And what was interesting in Australia was they came up with the ratios by asking nurses and even nurse managers, please tell us how many nurses you need, to care for patients safely. Tell us exactly the truth. Don't give us a higher number. Don't tell us you need a ratio of 1-to-1 on a med surg unit because you think if you tell us 1-to-1, you'll get 1-to-4. Tell us exactly what you need. And they did. They told them, 1-to-4, whatever. I mean, if we had those ratios today, we would then produce enough nurses, to fill those ratios, and we wouldn't have, the situation we have in hospitals today. I mean, you also clearly in a pandemic, if you're going to staff appropriately, you have to produce even more nurses, for this incredible situation where you might have, quarter of them out with an infection, right? So, but hospitals, haven't wanted to do that. They have abided by the same just-in-time supply chain of nurses that they do to computer chips and so forth. And then actually to importing nurses, rather than creating homegrown nurses, they're poaching nurses. We've always poached nurses from other places in the world, and now we're doing it again, when those places need nurses more than ever before. I mean, it's a serious problem, as you know. I mean, the same is true of nursing assistants and nursing home aides, I mean, we're now sending the National Guard, to be nursing assistants. I mean, this pandemic has just illustrated every flaw in the American healthcare system, of which
it's fundamental. Yeah, the fundamental issue here, as you and Jane have alluded to, is that we have a healthcare industry which is focused on extracting profit from the system, as opposed to a healthcare system that's focused on providing health care.
Exactly.
And between the mid 1970s and the mid 2010s, there has been an astonishing over 3,000% increase in the number of administrators in healthcare in this country. And all of the issues that you were talking about have got to do with this issue that there are 10 administrators to every practicing physician in American healthcare. And, just to give you, some of the other examples, the electronic health records and the computer issues is one component of it. Now, Gene, I don't know if you can remember, when I retired 3 years ago. In the last 10 years of my clinical practice, I was doing endocrine surgery, and most of that was outpatient. So I wasn't spending a lot of time in the hospital. But before that, I did a lot of cancer surgery and spent a lot of time in hospitals and ICUs and places like that, having patients taken care of and dealing with and seeing the nursing issues. Now, back in the 90s, if I remember correctly, not only were there nurses, but there were nurse assistants. There was what did they call the person that was there just doing the administrative stuff?
Ward clerk.
Ward clerks, yes. And so now these people are gone. I don't think ward clerks exist anymore.
Yeah, they still do in some places.
Yeah, but these administrative decisions were made focusing on the bottom line, not focusing on providing care. So my wife just recently retired as a VA operating room nurse, and one of the things that you alluded to, Suzanne, in terms of the supply issue. And this was in the VA, and she worked in one of the local hospitals in Louisville before that, and the supplies of equipment that were needed in the operating room were literally, as time went on, they didn't have a bunch of excess capacity there. And a lot of this had to do with the focus of the not of the provision of care, but of the financial issues in the system and the goal of extracting profit instead of providing care. what are your thoughts about you talk about the staffing shortages and the burnout. When I first came to Louisville in the 1970s, most of the hospitals, many of the hospitals had their own nursing schools. And the nurses learned floor nursing, bedside nursing. They were focused on that. There was maybe one administrator and a chief nurse, and then that was it. Today, the administrative staff in the local hospitals, you can't figure out who they all are. They have somebody in charge of advertising, somebody in charge of recruiting physicians, because physician groups now work in these healthcare systems that are run by hospitals. But anyhow, in your research and background, where do you, what sort of issues, how would you deal with the nursing staffing shortages in today, that where these hospitals no longer have nursing schools because they would get the nurses, they would train the nurses, and the nurses would work in the hospitals?
Now, let me just add before you answer that question, is they were called diploma schools, and they had one at Norton's and they had one at Baptist. And when those nurses finished after 3 years, they had spent a huge amount of time on the floors, and they knew exactly what to do, and they were were nurses.
Well, I think this is a broader point in healthcare education. The United States, I'm not an expert on this, but in other countries, certainly in France, I know France and other countries, you don't need a 4-year degree to become a physician. In France, it's a 6-year degree and you just go right in. You don't need a university education to become a nurse. So, I would argue that one way to get medical school debt down is, why doctors should just go in, learn the basic sciences and become doctors. And you probably do it in 6 years. And nurses in the same. I think you've gone in all healthcare, quote unquote, professions. Some of them obviously didn't exist many, many years ago, from an apprenticeship system, which is kind of what the hospital school was, to a university system. Does a surgeon need to take philosophy courses, or I don't know, an extra language? Maybe they do in America with Spanish, but you're never going to get the hospital schools back. I think that you need to figure out what the educational track should be. Should it be, now because of the competition with medicine, nursing so-called leaders have decided that a nurse practitioner has to get a doctorate and a 4-year degree. I think that's absolutely ridiculous. And that it just makes more money for the nursing schools. And now you have a competition of who should be called doctor, I think, doctors should be the MD and you should call the nurses Nurse Jones, that's a whole other thing. This first name thing in America drives me nuts. I'm a 76-year-old woman, and some, doctor walks in the room and says, "Hi, I'm Dr. Smith. How are you, Suzanne?" And that just doesn't work for me. And they call the nurse Joan, and they're the, Dr. Smith. I don't like that either. But that's all, in relationship to this hierarchy. And, hierarchy, I think that the COVID crisis has made the issue of staffing, of workload, of paperwork really critical, but we shouldn't ignore the issue of teamwork and the inability for folks to really take that seriously. Maybe things are better. I haven't really looked at relationships between doctors and nurses during COVID. Maybe this crisis has had a leveling effect, that's a sort of interesting sociological question. I just think that the what you talk about with administration, it's the same thing in terms of what David Himmelstein and Steffi Wohlhendler have so long illuminated, 30% of our healthcare dollars going to administrating, marketing, and profit, 10% going to fraud and abuse. I mean, you have, whatever, there's a huge amount of waste. That there's I think a view, I mean, you see the same thing with the shortage of primary care doctors, of mental health professionals, and even general surgeons. I mean, I'd love to interview you about that. I mean, we seem to have this notion that is like just in time supply, that there's this hot and cold running water of doctors, nurses, primary care doctors, nursing assistants, and you just turn the faucet on and they come out and you turn it off, and then, when you don't want it. And, they don't realize that it takes, 4 to 6 years to produce a nurse that can work functionally on a floor. It takes 10 years to produce a doctor, whatever, a mental health professional, a psychologist. You can't just suddenly decide, oh my God, we should order some more chips from China. It doesn't work that way. And it's called planning. And you've mentioned this, if your medical industry or your healthcare industry is planning to produce profits, well, they do a very good job. But if it's planning to produce patient care, if it's planning to produce health, if it's planning to produce a good death, they don't know how to do that. And then, if you talk about planning, it's socialism. I mean, I think we have to completely reimagine our healthcare system, and try to fight, for a healthcare system that has the right number of facilities in the right places to serve everyone with the right amount of professionals. I mean, we have a complete maldistribution of physicians in this country, what is it, 15% or 20% of people going into primary care. Congress has completely abdicated control. It won't say, we don't have enough money for the amount of doctors we need to produce, or if we have the right amount of money, it's maldistributed,
Well, again, this is the healthcare industry. Years ago, there was a surgeon in Louisville, whose name I won't mention, who had some vision problems, and he was a general surgeon. He went out of practice and ran for public office. And he became a member of the House of Representatives, representing an area where he lived. And he came to the Louisville Surgical Society, and this has got to be 20 years ago, and gave a really good talk. Told us that, one, the business of making laws was like making sausage, which we've all heard before. And the other thing he said, which was very, very telling, was that the politicians, he'd been in the House of Representatives for 4 or 5 years or so, don't have any idea. They just don't understand healthcare. Don't have any understanding of it. Jean, let me ask you now. The Atul Gawande. Can you summarize the activities that went on between Berkshire Hathaway,
really,
and those other 3 companies, and the conclusion that they came to after 3 years of that study that they put together, or those activities to try to figure out how they could improve healthcare in this country?
Gandhi is a surgeon from Boston, and is also an author, and it's written for the New York Times, and it's become a fairly famous doctor. And he took over this company, and the plan was to try to build a healthcare system in the private industry with 3 companies that
in
would
the private
work.
Industry model,
Right? A model,
yeah.
And it included one of the big banks in New York, Berkshire Hathaway, and a very large company in Seattle. And after 2.5 years, they came to the conclusion that it was impossible to do without government intervention. And so they shut the company down.
Yeah, the scary thing about that is, if you look at what's going on with our government today, I can't see any prospect of them getting together to do anything like that in any time soon. It took Japan 10 years to transition from the kind of healthcare industry functional system to the universal single system that they've got in Japan today. So,
well, I mean, I think it says a lot about Atul Gawande that he took this incredible ability to write and put it in the service of working with Berkshire Hathaway, JP Morgan Chase, and Amazon.
yeah.
Those were the three companies. So that, the Amazon, the biggest healthcare. I mean, how can a surgeon like Atul Gawande work with Jeff Bezos, who has probably one of the worst records in healthcare and how you deal with workers? You want to fix healthcare, you want to fix costs. Try having fewer occupational injuries. I'm a fan of Atul Gawande, and I think he's very corporate. He's made a lot of money. Physician greed is part of, not all, but there's a lot of greed that fuels this system, and physicians are part of that, just as all of us are part of it. But I think that, one of the stories that I thought was the most interesting when it comes to teamwork that Gawande ever did for the New Yorker, I think was called Personal Best. And I've written about this a lot, where he decides that, and these will be really interesting to you too as surgeons, but he decides that, he really needs to up his game as a surgeon. And he says, athletes, if they want to up their game, they get these kind of, elite coaches to come in, and he brings in some surgeon that he considers, above him. So somebody that he is willing to listen to. And this surgeon sort of observes his practice and sees that, essentially the problems that he has in the OR are around teamwork. He doesn't listen to people. He pushes people out of the way, so he can't see what they're doing. The surgical tech can't do this one can't do that. And he basically says, and this is really, astounding, and this is the elitism in healthcare. He says, I had to get this, fancy surgeon who is senior to me, who I respect, because there's nobody else in the OR that can, make observations about my actions. And I'm like, hello, there are all these people there that if you just ask them, how you could improve, or how we could all improve, would tell you. And, but it's like this administrative problem. You have to get, the frontline staff involved. You have to get them all involved, and you have to ask them what they need to do their jobs better. And there's an assumption, I think, in healthcare that, there's some people who do mindful work, and there's some people who do mindless work. You see the same in nursing, nurses. If you talk to a nurse's assistant or an LVN, a licensed vocational or practical nurse, she will talk about RNs, registered nurses, exactly the way RNs talk about MDs. People do not have collaborative relationships with each other. And then you have administration and the healthcare industry obsession with profit overlaid on this system, and it's bound to create serious problems. I think the thing that we need in healthcare, we need so much, but, when it comes to nursing, I'd love to bring a bunch of nurses, doctors, nursing aides, the whole crew into a room and just sit them down and say, okay, you have 3 days. We're not opening the door. You can go to the bathroom. You can go to sleep. You can eat dinner together. You're all going to be around the table. You're all going to be on a first name basis, and you're all going to speak, and you have a really great facilitator. And what do you need to do your work efficiently, I bet you they won't say we need, 10 administrators to each one of us. I bet you.
When just to make a comment about your issue about what's going on in the operating room, when I had to have my hernia repaired about 6 years ago, the last person I was going to ask about who should be doing my hernia repair were other surgeons. So there were two groups of people I asked. One were operating room nurses, because they're in there watching what's going on, and the other two were residents. And I got a series of recommendations, and they all fundamentally focused on one person whose name I'm not going to mention, but I didn't go to a source because most surgeons don't know what the other surgeons are doing. Because they're not in the operating room with them, and there's a lot of that. We're getting close to the end of the lollipop here, so I just given you a warning. I think Mark's been waving 5 fingers at me. So
one of the things that before we end is collaborative care, which I think is very important. And one of the things that I've observed is that like in one hospital, you can have in one department very happy nurses and doctors who are working together very nicely. And then on another department, you can have very unhappy nurses.
Yes.
And I've observed that probably the reason for that is their managers and how their immediate supervisors are dealing with them. And I also know of a hospital where the pay is not as good, but the nurses and respiratory therapists, et cetera, all love to work there because they like the people and they like the managers. At the other hospital, they're unhappy because of their nursing management. And I think that one of the things hospitals need to work at is management, and there needs to be a personal relationship with these managers. You don't need people sitting behind the desk communicating with text messages and emails and not even know who they are. And that needs to stop.
Well, the problem is it isn't. Not only is it not going to stop, it's getting worse.
Yes,
because when you've got private equity companies buying up nursing homes, pharmacies, physician practices, and everything else they can get their hands on, that administrative a circumstance, the corporatocracy of running medicine is worse.
Yes, absolutely. I'll give you an example of that. I try to get involved in wound care in some nursing homes, and the local manager could not make a decision. It was being made by a corporate entity that lived miles away and had absolutely no idea what was going on at that nursing home, or my skills, or anything about the nursing home. It was like a big business decision. And every time we try to come up with a solution, it's always a high-tech solution. Instead of a simple solution like sitting down at the bedside and talking to the patient.
Right. Suzanne, we're down to the end of the lollipop here. 2 minutes, I think. Okay. Yeah. If you were the queen of the country and you had to pick 3 things that you could do as the dictator, benevolent dictator, queen, or whatever you want to be, to fix healthcare in the country, what 2 or 3 things would you say? Number 1, number 2, and number 3?
Well, I think number 1 would be to have a payment system, some kind of single payer payment system, and to ban profit, from healthcare. We shouldn't have for-profit hospitals. We should.
I absolutely agree.
We should not have private equity. I mean, it's getting worse. Private equity, is even worse than the usual for-profit. It needs to be local. I think you need to have real coordination of care. That's why I like the VA, because when it works best, the care is coordinated, and we could talk about that. I mean, that's a very important issue. Most people don't understand what that is because they've never experienced it. I certainly haven't. And I think that you have to have, workforce solutions developed by the workforce.
Suzanne, thank you very much.
Huh.
I think we're done. We enjoyed having you on. As always, your comments are interesting and to make attentive. Mark is about to make his final comments here, and we're gonna end.
Well, Suzanne, one last thing. Can you tell our listeners if you have a website or an address where they can reach out and get more information?
Sure. My website is SuzanneGordon.com. If you want to look at my work in healthcare reform in the VA, it's the Veterans Healthcare Policy Institute, veteranspolicy.org. You can reach me through my website. I've written a lot of books. You can go look at them, preferably buy them from an independent bookstore instead of Amazon. And I think that there's a lot that can be done. I think a show like this is really invaluable. And I really am very appreciative that you've had me on for a second time. And I love this kind of conversation. And imagine if this kind of conversation could take place with lots of different healthcare workers. Imagine what amazing solutions we would come up with.
Good deal. Thank you very much. For folks who want to learn more about Kentuckians for Single Payer Healthcare, you can go to kyhealthcare.org. If you'd like to reach out to our chairperson, that's nursenpo@aol.com. That's KTELO's address, nursenpo@aol.com. The group also has a Facebook page. Kay and Harriet keep doing their Twitter accounts. So we will see you guys again next week. Suzanne, thank you very much.
Thank you so much.